Kaya?
Kaya.
Churupin nunuk jinani nala kata jini nungo mot bedaya kayan kadak naja buja. I respectfully acknowledge the past and present traditional custodians of this land on which we are meeting, the Nungo elders and people. So, ladies and gentlemen, it's my pleasure to welcome you to the second event in the West Australian ECU lecture series. And our event this evening features Professor Rob Newton, ECU Foundation Professor of Exercise and Sports Science. And in a moment, he will speak on the topic, Exercise is Medicine. Now, each month, the West Australian ECU lecture series provides a forum for an ECU professor to discuss a pressing issue facing our community, to outline their research in the area, and hopefully engage in discussion with colleagues and the public. Because research not communicated is, in my opinion, research not done. Because it is the job of a professor to do what, Margaret? To profess. And that's exactly what Rob is going to do this evening. Now, ECU is very proud to partner with the West Australian in this exciting series, and we welcome Lee Fletcher, Marketing Manager from the West Australian, to our event this evening. Just before Rob gives his lecture, I thought I'd just give you a little bit of background about Robert Newton. So he graduated in 1986 from the University of Queensland with honours in his Bachelor of Human Movement degree. Wow. He then completed his Masters in 1992, and in 1998 he completed his Doctor of Philosophy at Southern Cross University. Now, prior to his appointment at ECU, Professor Newton was director of the Biomechanics Laboratory at Ball State University in Indiana. And he's also worked at Pennsylvania State University as a visiting research fellow, and he was there in the Centre for Sports Medicine. As I mentioned earlier, Professor Newton is the Foundation Professor in Exercise and Sports Science, and he's also the co-director of the Health and Wellness Institute here at Edith Cowan University. In addition to that, he's an accredited exercise physiologist, a certified strength and conditioning specialist. That's a weightlifter, isn't it?
Sort of.
Pretty much. And he does that with distinction, so maybe we'll get some weights lifted later. He's a fellow of the Exercise and Sports Science Australia and a fellow of the National Strength and Conditioning Association. Now, Rob has published over 267 scientific journal articles. Fantastic. 3 books, 16 book chapters, and with his work cited over 18,000 times. So this is research of impact. As of 2015, his research had attracted over $20 million in competitive research funding. Now, in his presentation this evening, Rob will reveal insights from his major research directions, including reducing decline in strength, body composition and functional ability in cancer patients, cancer-related fatigue, and the influence of exercise medicine on tumour biology. I think that will be really fascinating. His work in this area has contributed substantially to our understanding of the mechanisms through which exercises impact all body systems and how these systems respond and adapt to a range of stimuli, including all forms of anabolic, that's resistance to you and I, and aerobic exercise, as well as diet and nutrition supplementation. Later, you're going to have the opportunity to ask questions, and that will be chaired by Professor John Finlay-Jones. But without any further ado, please join me in welcoming Professor Rob Newton to the lecture. Rob.
Thanks, Steve. Welcome, everyone. Let's get started. I've got lots to tell you, lots to show you. For the past 30 years, we have been researching an exquisite medicine. It's proven to be effective in the management of all chronic diseases, including cancer. It's the only effective intervention for treating sarcopenia. That's the loss of muscle as we age or if we are unwell. And also to slow the functional decline, which is one of the major problems that we face as we age or through illness, and the treatment side effects that occur with many of the diseases. It's proven to reduce clinical depression by 60%. This is compared to 25% for routine GP care. And I apologise to the GPs, this is not my research. It slows or even reverses cognitive decline. It drives neurogenesis and is proven highly effective for treating Huntington's. Research actually done here at ECU with Mel Zimmer's group. Alzheimer's disease, research done by Professor Ralph Martins and his group here at ECU, and also Parkinson's disease. A form of this medicine completely blocks bone loss in men receiving hormone therapy for prostate cancer. This was a world first done here at ECU. It lowers cholesterol and blood pressure. It enhances immune function and greatly reduces cardiovascular and metabolic disease risk. I must admit I'm really struggling to read that back screen. So bear with me. This medicine is critical in the management of obesity, particularly to prevent the side effects of gastric surgery and dietary restriction. All weight loss programs are not just a fat loss program. They are also a muscle and bone loss program. And this is a major issue which this medicine actually prevents. Applied as an adjunct to chemotherapy, it increases the effectiveness. It reduces toxicities such as fatigue and nausea, and improves tolerance. And some very solid research from our colleagues in Canada, Professor Kerry Cornier, has showed that it actually increases the patient's ability to complete the full course of treatment. And that is very, very important for enhancing their survival. It slows progression, or it can even reverse type 2 diabetes. It is currently the only known cure for type 2 diabetes. It reduces prostate cancer-specific mortality by 60%. More than doubles your chances of surviving. It has the same effect for breast cancer and colon cancer. It improves sexual health, including increased libido, and reduces erectile dysfunction in men with prostate cancer. Again, world first research done here at ECU by one of our colleagues, Dr. Prue Cormy. Is everyone getting dizzy yet? Just to keep you awake. It's effective, safe, and tolerated for all cancers, regardless of disease stage. Even when undergoing difficult treatments, this medicine is safe, it's effective, it works. Applied pre-surgically, it reduces hospital stay, there are less complications, faster recovery, lower erectile dysfunction, and lower bowel and urinary incontinence problems. We'll see later in my talk that it actually suppresses tumour cell proliferation. It reduces metastases, and it actually drives cancer cell apoptosis or death. There are no known side effects. This medicine is exercise. Exercise is medicine. Thank you for coming along tonight. As our illustrious leader pointed out, my name is Rob Newton. I am overwhelmed by the turnout to hear my talk. Thank you so much for your support of the West Australian lecture series. I love working at ECU. I've been here 13 years now. It's been a fantastic environment for us to work. Let's go and talk and see some of the work that my team and I have actually been able to achieve over the last decade or so. Physical activity versus exercise. The World Health Organization defines physical activity as any bodily movement produced by skeletal muscles that requires energy expenditure. It's pretty broad. But the World Health Organization is also explicit that the term physical activity should not be used interchangeably with exercise. Because exercise is a subcategory of physical activity. It's planned, structured, repetitive, and purposeful, in the sense that we are seeking improvement or maintenance of one or more components of physical fitness as the objective to improve health. Now, exercise medicine is becoming increasingly established as the term to describe the physical assessment and prescription of exercise specifically for the prevention and treatment of injury or illness. Specifically, exercise drives endogenous medicine. When we exercise, our body chemistry changes markedly. It affects every system in our body. It has direct structural, adaptation and repair mechanisms. It facilitates other therapies, as we'll see. On present knowledge, exercise offers the greatest potential as an adjunct therapy to reverse treatment side effects and increase quality of life and quantity of life in people with cancer. Exercise may be a powerful medicine to slow or even reverse tumour growth. Now, when I first came to ECU, I was mad keen to pursue exercise in cancer. And the reason why was that a few years before that, my dad passed away from prostate cancer. And he was diagnosed with prostate cancer. He had a full prostatectomy. He then went up to Brisbane and had radiation therapy for 6 weeks. He was told he was cured. He went home. He sat in the sun on the front porch. 2 years later, he died of a stroke. What I observed was the incredible fatigue that he experienced and the impact that the therapy, the radiation therapy, had on his body. He lost all of his muscle mass. He lost his function. He was no longer able to perform tasks of daily living. His quality of life in particular was heavily impacted by this. And so he sat and waited in the sun and basically just withered away. When I observed this, I knew there had to be a better way. And being an exercise scientist, I knew that we could address a lot of these side effects, in particular the loss of physical function, this overwhelming fatigue, and the loss of muscle mass. So when I came to ECU, appointed as the Foundation Professor of Exercise and Sports Science, I wanted to pursue exercise research in cancer, in particular prostate cancer. And I asked, as part of my startup package, for a couple of PhD scholarships. And I was very lucky very fortunate to recruit an outstanding candidate in Daniel Galvão from the University of Queensland, originally from Brazil, who came to work with me, and we launched a very exciting and wonderful career in research in this area. So our first paper that we produced was actually a review, and we looked and said, well, we better find out what's going on so far. And we looked at all of the exercise studies, intervention studies in cancer patients up to June 2004. Can you believe it? There was only 26. That's all that had been done. This is only a little over a decade ago. And the paper we presented from that was published in the Journal of Clinical Oncology, which is ranked either 2 or 3 in the world in the field of oncology. You'd never get this review in that journal now because the field's advanced so much. But we reviewed those trials. The majority of them were in breast cancer, and just about all of them used cardiovascular exercise or aerobic exercise as the intervention. Very pleased to say that paper has received 434 public citations, so it's been cited by other papers over that 10 years. Now, it was interesting because what we observed from these studies was an overwhelmingly positive effects. And this was despite the fact that the exercise prescriptions were suboptimal. When I looked at them as an exercise, or more specifically a sports scientist, and saw what they did with these patients, I go, why would you do that? It's not the way in which you would manage the human. It's certainly not the way you would manage an athlete. And so what we need to do is to draw on the enormous body of knowledge which we have around human performance, and in particular in the elite athlete. This area of research goes back millennia. The ancient Greeks did extensive work, including a lot of supplementation, with their athletes. This is a body of science which is very large and has a very long history. We need to draw on that enormous understanding of how the human performs. And that also translates to the patient. Survival. Thought I'd start off on a high note. This was published in the Journal of Clinical Oncology again, way back in 2006, almost a decade ago. It doesn't seem that long, time flies. And this was actually the editorial for that journal. The editor wrote, "Cancer survival, time to get moving, ? Data accumulate suggesting a link between physical activity and cancer survival." And at the time, they were actually referring to a couple of papers. And the first one was an earlier study by Holmes and others. And this was looking at around 3,000 female nurses diagnosed with breast cancer. And what they found was that the relative rate of death was about 0.5 to 0.6. When you compare those that did less than 3 med hours per week versus those that did 9 med hours or more. So I'll explain that. 1 med hour is equivalent to approximately 20 minutes of walking at a normal pace. 9 med hours is not a lot of physical activity in a week. In fact, you could do it in just 3 hours of walking per week. You could hit that magical 9 med hours, and if you have breast cancer, you are doing a lot towards reducing your risk of actually dying of that cancer. It's only 77 minutes of jogging. I like to get it over with, so it's good to go a little bit quicker. So this is again from this same study here, and what they found interestingly was this is less than 1 hour per week, and that's given a relative number of 1. And you see about a 20% reduction for 1 to 3 hours of activity. When you go to 3 to 5, you've got a 50% reduction. And you don't get much more benefit by doing additional physical activity in this particular study. Now, also published in this particular issue, and what really drove this, the editor to write the piece, was that Mayhart and others, there was 2 papers published in this edition, and it was in colorectal cancer patients. And what they found was those that did 3 med hours per week of physical activity compared to 18 plus, again, they had about a halving of their mortality rate. So a considerable improvement. The interesting thing was it wasn't influenced by gender, their body mass index, age, or the chemotherapy that they received. They're a little bit modest here. They said physical activity appears to reduce the risk of cancer recurrence and mortality. I think a doubling your chances of survival is a pretty good bet. Now, this is drawn straight from the editorial, and what they stated was data from these studies suggest a reduced risk of recurrence of between 50 to 60%. And this is a direct quote. Such an effect parallels that of, we call it Herceptin here, for HER2 positive breast cancer patients. An agent, when it was released, was heralded by the oncological care community and by the director of the National Cancer Institute, describing this particular chemotherapy agent as a major advance and turning point in eliminating suffering and death from cancer. Appropriate physical activity has the same survival advantage. However, exercise is not an alternative to chemotherapy. So don't give up your chemo. But it is a critical synergistic medicine. And I'll show you some data shortly where it greatly increases the effectiveness of other treatments such as chemotherapy, radiation therapy, etc. Okay, let's turn our attention to another study. This is actually a paper from some colleagues of ours at the University of California, San Francisco. This paper was led by Stacey Kenfield. And they were looking at very large numbers of men with prostate cancer, and they looked retrospectively, and what they found was that those that did 3 or more hours per week of vigorous activity basically halved their risk of all-cause mortality. It's good. But they had a 61% lower risk of dying specifically from their prostate cancer. Important here to note it was vigorous. They didn't see anywhere near the same effect for less vigorous activities. Here's some more data just to nail home the point. Physical activity and survival among men diagnosed with prostate cancer. Here, what we see is those that do less than 5 med hours per week. Here, that's the solid line, and the dashed line is 5 or more hours per week. You quickly see a separation here with better survival, considerable advantage there. Looking specifically at walking and cycling and overall mortality, again, considerable benefit for those that did 20 or more minutes per day of cycling or walking. Some other data from a study last year here from the Mayo Clinic. This was in around 2,900 cancer survivors. Again, this is looking specifically at resistance training. And they looked at cancer survivors who did or did not perform resistance exercise, so weightlifting. So the blue colour is those that actually lifted weights. And they saw an independent effect of resistance training, once again enhancing survival in these patients. So there appears to be something different about different types of exercise. It does seem to have different effects. If you like medicine, it's not a single medicine, it's many different types of medicines. And in fact, what they saw was a relative risk just due to undertaking resistance training, a 33% lower risk there, once again taking into account all other potential confounders, including their base level of physical activity. So resistance training gives an added survival advantage over all other behavioural aspects that they have. So on the basis of this, a growing body of research evidence and clinical experience, there's been several position statements which have come out to actually describe the effects of exercise for cancer patients. The first one was published in 2009, and it was from Australia. So the first guidelines for exercise and physical activity for cancer patients actually came out of Australia. It came out of ECU. And you'll see Daniel Galvao and myself co-authored that paper with a group from QUT. And then that was our paper. Then in 2010, the Americans caught up, and the American College of Sports Medicine, which is arguably the world authority in terms of exercise and sports science, published a paper, and I'm very proud to say that Daniel was a co-author on that expert panel. And then in 2011, the American Cancer Society came out with their position statement in terms of exercise and physical activity. Very high consensus among all these position statements. Every week, a cancer patient, cancer survivor, should try to do between 70, 75 and 150 minutes of moderate to vigorous aerobic exercise. 2 or more resistance training sessions. Once again, exercise is not a single medicine. You have to treat it with the disease with the appropriate medicine. The problem we're seeing with this now, whilst this is a fantastic guidelines, it has changed clinical practice markedly. It has changed the behaviour of some cancer patients. It is perhaps polypharmacy that we're putting out there. We're throwing a whole lot of things at the patient and hoping that something's going to work, something will stick. I think that what we need to do now, the challenge of course, is to move from generic prescription to a more tailored prescription to increase the effectiveness. The problem we have is that the majority of cancer survivors are totally sedentary. Our team published a paper recently where we reported that actually 86% of Australian men with prostate cancer do not meet those guidelines, despite the huge volume of evidence suggesting that we will more than double their survival chances. Remember too that this is general physical activity as well, not targeted exercise medicine. I think we'll see much greater effectiveness and compliance if we actually use targeted exercise medicine to address the issues which are most compromising the patient's quality of life and, of course, their health and survival. I won't present the data for all cancers, but they're very similar in terms of the recommendations. This is from the American College of Sports Medicine document. This is treatment during and after cancer diagnosis, or treatment, sorry. And this is the evidence. Category A is overwhelming evidence from randomised control trials. So the strongest level of scientific evidence that you can have. Evidence for safety. A, improvement in aerobic fitness, muscle strength and reduction in fatigue is all evidence at level A. Body size, composition, quality of life, physical function, a little bit lower, but is still very strong evidence that exercise is safe and highly effective for people with prostate cancer. So I'm going to change tack a little bit now, just talk about some of our specific research that we've done in prostate cancer and in particular hormone therapy. Now, Very, very common with a man who is diagnosed with prostate cancer is that he will receive chemical therapies, hormone therapies, to prevent or exclude the prostate cancer cells from accessing testosterone. Prostate cancer cells proliferate in an environment where they have access to testosterone. So the man is given hormones either to prevent the production of testosterone or to actually block the receptors on the cells so they can't actually receive the signalling. And it's being used increasingly in the management of prostate cancer. It is highly effective. In the majority of men, it will slow or completely stop the progression of the actual prostate cancer. The problem is that there are significant adverse effects that go along with this. You have a man who's spent perhaps the last 60 years in an environment with a high level of circulating testosterone, and then you switch it off in a matter of 6 weeks. They go through the equivalent of menopause over a 6-week period. It's an extremely difficult time, both emotionally, psychologically, but also very hard physically, as we'll see. So this has been raised as a considerable concern. A number of articles, this is a bit of a key one here in the Asian Journal of Andrology, because patients and clinicians as well are becoming increasingly concerned about the issues of muscle loss, cardiovascular disease, heart disease, the effects on cognition of withdrawing testosterone, and also in terms of the pancreas, because we see a much higher rate of type 2 diabetes once men go on this therapy. In fact, there's several reports showing that many of these men die within 2 years because of the metabolic syndrome that they develop and the complications that go with that, not from the prostate cancer, but from actually the therapy, the androgen suppression. So this is a major concern because many patients were actually refusing to take the therapy, and this is possibly not a good outcome because it's very effective at slowing the disease. So we have to look at ways in which we can actually manage these side effects. The side effects are considerable. Muscle loss is a major problem. You take testosterone, a very powerful anabolic hormone, you remove that and they have a very rapid loss of muscle. That's a problem because it really impacts function. It really affects all the other systems, as we'll see, because the muscle system is a major mediator of all the other systems in the body. They lose strength, decline physical capacity. Their balance is impacted because testosterone is highly neuroprotective. It's very important for neurofunction, including movement, and they have increased fatigue, so it's problematic. So on the basis of this, we were actually asked by our clinicians, who are very important to us, our clinical collaborators, and one of our early studies, which we published in the British Journal of Urology International, was to actually track these men over the initial 36 weeks of maximum androgen blockade for their prostate cancer. And this is baseline and 36 weeks, and this is the percentage change. Now, the first thing to note is that the ADT works. Their testosterone dropped from 15 to 0.8. It's a 93% reduction. It was highly effective because also PSA, prostate-specific antigen, which is a very nice biomarker for activity of the prostate cancer cells, dropped by 98%. The therapy works. It's highly effective in the majority of men. The problem is they also lost 2.4% of their lean body mass, in particular their arms and legs, and their fat mass increased by 14%, including the fat around their trunk increasing by 12%. This is only in 36 weeks. Some of these men will be on this therapy for 5, 10 years. This is what's driving a lot of these metabolic disorders and ultimately their mortality. But if you have a look at all those things, they are aspects which should be highly responsive to appropriate exercise medicine. Muscle loss, fat gain, strength loss, they are all things which should be able to be managed through appropriate exercise. So our team launched on a series of trials to evaluate exercise interventions in different cancer populations. The first one we'll present will be around prostate cancer. So one of our early studies was in men with prostate cancer. They all had androgen deprivation therapy. About 24% had also received radiation therapy. It was a randomised control trial. Around 60 men in this particular intervention. It was only short, 12 weeks. It was a combination of weight training, resistance training, as well as aerobic training. That's the protocol there. Our primary endpoint was lean muscle mass. The reason for this was, until this time, we did not know whether men who did not have access to testosterone would actually be able to increase their muscle mass. Testosterone is a highly anabolic hormone. It's very, very important for body function. If we take it away, will they actually be able to respond to exercise, their muscles to actually grow larger, which is such an important thing, not only for function, but also for metabolic health, as we'll see. It was not known at this time. No studies had evaluated it to this point. We were very pleased to report, this was published again in the Journal of Clinical Oncology, approximately a 1 kilogram gain in lean muscle mass in these men. They got a lot stronger, their aerobic capacity improved, that's because it's a negative indicating they can do the test in a shorter time, their balance improved, some nice improvement in quality of life here, in particular reduction in fatigue. C-reactive protein decreased, meaning that their overall systemic inflammation was reduced, which is a really important outcome as well. What was also important was that there was no increase in testosterone or PSA. This was a concern of ours because normally in men who are unigonadal, in other words, they have normal testosterone, if we put this on this program, their testosterone would actually go up. Now that would be a problem for a man with prostate cancer. The clinicians, our close colleague Professor Nigel Spry, assured us that it couldn't happen, and it didn't. There was no change in testosterone, no change in PSA. So this was one of the first studies to demonstrate worldwide that exercise would not actually compromise therapy intent. And that was important because we wanted to get across to clinicians that, hey, this is not going to do harm. The next study I want to present is actually looking at different exercise modes. This was a study funded by the NHMRC. This is the protocol paper for it. A much larger trial this time, 163 men, 12-month intervention, so it was much longer. And we had 3 different groups. One was a group doing impact exercise and resistance training. The impact exercise, I'll give you some more details later, but it was actually doing things like skipping and hopping and jumping to try and impact the body. And resistance training. The second group was doing weight training, resistance training and aerobic exercise. The third group was a usual care control. So they spent the first 6 months just doing usual care, what they normally do. And then we moved them on to 6 months of aerobic training. Again, our primary endpoint was lean body mass, but also bone mineral density to try and stop the loss of bone that occurs and to increase their aerobic capacity. So this is some of the results from this study, which we presented at the American Society for Clinical Oncology meeting, huge meeting in Chicago, presented last year, and it was also published as an abstract in the Journal of Clinical Oncology. And these are the changes that we saw. The first one, muscle strength here, considerable improvement, in particular with the group that performed the resistance and impact training. Much lower for the group doing the aerobic and resistance training. These are just different exercises here. But also looking at the changes in whole body lean mass, we see a really nice improvement over about 1.5 kilograms in the first group here, much less so for the aerobic and resistance training, and of course no change for the delayed group who didn't do any exercise. Why is this important? These two groups were doing the exact same resistance training workout, no different. They should have produced similar improvements in muscle mass, but they didn't. The difference is this group was doing aerobic exercise as well. And what we hypothesised, but we need to look at in more depth, I apologise, let's go back, is whether the different types of medicine, exercise medicine, are actually interfering with each other. There's a reason why this is suppressed, and is likely the interference effect that we have, that we observe to a very small extent in elite athletes. Elite athletes, we wouldn't give them the same type of training together for aerobic training, resistance training, because they interfere slightly with each other. It appears that in this patient group, the interference effect is much larger, likely because they have compromised immune system, compromised ability to respond to different stimuli. But that's an interesting area, and certainly we're going to need to look into that to drive our exercise prescription and make it more effective. Next study I want to present to you was a study with 100. These were older men. These were men who had been through androgen deprivation therapy, been through radiation therapy, and they were cured, if you like, And we wanted to follow them up and see, well, can we actually give them exercise and improve their capacity? So it was 2 groups here, getting resistance and aerobic exercise, and then there was another group, which, if you like, was usual care, but we gave them we really stressed physical activity, and we gave them actually information on physical activity. So if you like, a public health type approach to trying to get them to be more physically active. Well, interesting, the results. This is their aerobic capacity. We see that this is the actual time, so going down is good. And we see the exercise group in red, really good improvement, no change in the group that received physical activity recommendation. Take-home message, if you tell your patients it's really important to do physical activity, hardly any of them will do it. Okay? If you actually put them in with an exercise physiologist in a supervised program and you monitor them and you give them feedback, you'll get a much higher compliance to your exercise intervention. Also in terms of chair rise, this is a functional test again. Here we have in terms of strength in chest press and a leg press exercise here. Some really good improvements by the group that actually received a supervised exercise program. And even when they went on to a unsupervised self-managed program, they maintained quite well. So if you get that initial 6 months, you teach them how to exercise, you give them a good program, you support them, you can step back a little bit and they will self-manage themselves quite well and continue on. Not so if you just look at the other group, the usual care group. So that was an important take-home message. This is some of the quality of life outcomes that we had from this particular study. Physical functioning, social functioning, etc. This is the 6-month, and then in purple is the 12-month data. And we see, once again, this is the difference between the 2 groups. And we see a considerable benefit of face-to-face supervised exercise. And importantly, in these very old men who've been through all this treatment and radiation therapy as well, they retain the ability to respond and to actually improve their physical capacity. Now, we published that paper in the European Urology, and it was it generated such interest that it was actually pushed through as a platinum priority and actually received an editorial attention. And this was the editorial, which included Dr. Lee Jones at Memorial Sloan Kettering, who works with our group a lot and has been out to visit recently. And they actually wrote up an editorial here saying, exercise as treatment for androgen deprivation therapy and associated physical dysfunction, is it ready for prime time? Because based on the results of our study, they're saying, hey, we've got to seriously look at this. We've got to make this as a very high priority for men on ADT to get them into quality supervised exercise programs. But there's some more side effects of androgen deprivation therapy. And the ones I want to cover off on now is something which is causing major problems for a lot of the patients, and that is the issue of osteoporosis and skeletal fractures. Because, of course, if a 65, 75-year-old man fractures a hip, the outcomes are not good. So this is some data just showing the prevalence of this problem. These are men looking at them on various lengths of androgen deprivation therapy in years here, from not receiving ADT through to up to 10 years of successive androgen deprivation therapy. And we see that by 10 years, 80% of those men will have osteoporosis. The other 20 will be osteopenic, the early stage. None of them will have normal bone density. So this, again, is a major problem because, of course, for these men, they have low muscle strength, poor balance, they're more likely to fall. If they do fall, they're more likely to fracture. So this is the actual intervention that we did, the impact exercise that I mentioned a little bit earlier. Various exercises to try and load the skeleton appropriately. The skeletal system responds to loading changes in actual force, and it only responds to the initial few, perhaps 13, 15 minutes of this loading, and then it no longer responds. And so we had the guys, these are all men on androgen deprivation therapy. They're all in their late 60s through to their 70s. Now, folks, don't go home and drag your grandmother off the lounge. Okay? This was very closely supervised by our exercise physiologist. They had an extensive preparatory period of heavy resistance training to get their structures ready and their strength up so they could perform this type of exercise. Okay? How's our insurance policy going, Vice-Chancellor? Okay, so to the results. We had 3 groups in this particular study, and we see here, this is the change in lumbar bone mineral density over the initial 6 months. And this is a usual care group, so they were our control group, and you see that they lose over 3% of their bone mineral density. This is a catastrophic rate of loss of bone density. Okay, it's actually far higher than what a menopausal woman experiences. This is what shocked me as an exercise scientist. This group was doing heavy resistance training and cardiovascular exercise, had no benefit at all in terms of reducing the decline in bone. That surprised me. We've given this same program to menopausal women, old men, older women who are not on testosterone suppression, and they've responded very, very nicely by either maintaining or actually increasing their bone density. But this intervention is not sufficient to overcome the effects of testosterone suppression in these patients. However, the combination of resistance training and impact loading totally obliterated the bone loss. So this was an extremely important outcome, and it makes a very important point. Many groups have compared usual care to resistance and or aerobic training and found no benefit. If we would have run this study with these 2 groups, we would have concluded, as other groups around the world have, that exercise is ineffective for slowing bone loss in men with prostate cancer on testosterone suppression. So you'd move on and look at something else. It was only because we planned this group that we actually showed a benefit. The take-home point here is exercise is not a single medicine. It is many different types of medicine, and how it is actually prescribed and delivered has very different effects. This was a world first for ECU. Okay, changing tack again. Our clinicians were reporting to us that men with advanced prostate cancer were doing quite poorly. The recommendation at the time was in general for them to rest. Clearly, these men are quite unwell. They've been through a lot of treatment. They're likely to have had androgen deprivation therapy, radiation therapy, and then they may actually move to maybe chemotherapy or even more heavy, if you like, advanced drugs for testosterone suppression, some of the new drugs which are now available. But our clinicians were saying that their function was really declining and these guys were not doing well at all. Could we actually exercise them? And at this stage, the general recommendation was that we couldn't because in this particular group, they had bone metastases. In other words, their prostate cancer had actually spread from the localised area of their prostate and was actually into their bones now, and it was actually proliferating. Now that creates a lesion on the bone, which is an area of weakness, and is at risk of a spontaneous fracture. And of course that creates obviously enormous, you can imagine a spinal compression or something like that. Now you've got a major life-threatening issue for the patient. But exercising or not exercising, rest is not an option. All of the research shows that we must reject the rest option and that these patients must perform some amount of physical activity regardless of their disease stage or the type of disease or undergoing difficult treatments. So we thought, right, we'll give it a go. And so what we did was we came up with a protocol, this is the protocol paper here, where we looked at a multimodal exercise program where we would exercise them but not load the sites where they had bone metastases. And so the program we came up with, depending on the site of the metastases here, we would adjust the actual prescription to avoid loading the site, to reduce the risk of actually fracturing. Why would we do this? Once again, we just drew on the enormous volume of knowledge that we have about training elite athletes. Is Anne here? She promised me she'd come. Anne Johnson. Anne? I promised I wouldn't mention the Dockers. Did you notice I had a photo? If one of the Dockers, hurts their knee in the game, we don't give them 6 days off. They're in the next day. Your knee's bad? All right, we'll work on your upper body, your shoulders, and we'll work the other leg. Same principle. We were just applying what we'd learnt in elite sport to the patient population. We have to exercise them, we just won't target that particular area. So it was a little bit of a risk because this was a high-risk population. would this actually work and would it be safe? And so this was a paper published, and Prof. Cowan led this particular paper here, published in Prostate Cancer and Prostatic Diseases. And looking at the safety and efficacy, again, this was a world first. No one else has ever exercised this patient population. They've told them to rest. Well, what did we find? No adverse events during any of the exercise sessions. Attendance, the average was 20. In fact, 70% of the patients attended every single session that was prescribed, the whole 24. Compliance, very high. Perceived tolerance from 0 to 7, they rated it 6.1, highly tolerable. Severity of bone pain, 0.6 out of a possible 10-point scale. Incidence of bone pain affecting their ability to do activities of daily living, 0. No between group difference in bone pain, no change in use of pain medication over that 12 weeks. So it's safe, it's well tolerated, and the guys enjoyed it. They got benefit from it. However, these guys have been under a lot. They've had a lot of treatments. They're quite unwell. Can they actually respond? Can they get better? Well, this is the results from here. No change in bone pain, but we saw some nice improvements in muscle strength, aerobic fitness. Their walking improved. They actually increased their lean muscle mass as well by 1.7 kilograms. And their physical activity increased markedly by over 20%. This is activity outside of the intervention that we were doing. Because they felt better, they felt stronger, they played more golf, they walked the Labrador more, did all these really important things that contribute to quality of life. So we got them up, we got them moving, we got them better. But where do we go now? There's emerging research indicating that when bony metastases sites are loaded, it actually suppresses the tumour development. Now, at the moment, the research is only available in animal models. This is just one study here. This is in a rodent model here. What they had was, so rats, and what they did was they put human metastatic breast cancer cells into the tibia of rats, and then they had some of them exercise and some of them not. They actually loaded the tibia, so they were putting force through the actual area, what we tried to avoid. And this is the results. What they saw here, this is, I'll just take you quickly through this graph. This is the actual integrity of the tibia here. We see that this is at 2 weeks and this is at 6 weeks. At 6 weeks, the loaded condition was still at 100% in terms of animals with intact tibia. The unloaded animal, the animals that were just allowed to do normal rat things, what we see here is that over 80, almost 80% of those animals no longer had intact tibias. If we have a look at tumour growth, looking at the histology here, we see loaded, we only see a marginal change in the percent of tumour-bearing animals here, but 100% of the animals that didn't have this loading actually had drastically developing tumours in their tibia there. So the conclusion was mechanical loading dramatically reduced osteolysis, tumour formation, and increased tibia cancellous mass due to trabecular thickening. What that means is their actual skeleton integrity was being maintained and the tumour was being suppressed. There is some form of chemical signalling going on. When we stress the bones are releasing actual signals. They're signalling to the tumour cell and they're suppressing the tumour cells in some way. Now, this is the basis of a new exercise trial that's being led by one of our postdoctoral fellows, Dr. Nicholas Hart. And we have a study currently under evaluation by the National Breast Cancer Foundation to look at this particular, very the same issue here, looking in women with metastatic breast cancer. So we need to do it in humans. Changing tack entirely again. This is now, I want to turn attention to sexual dysfunction, and I'll tell you a funny anecdote. Daniel and I were over at the Prostate Cancer Foundation. They have a conference. It was over on the Gold Coast, and we were presenting and gave our talk, and we were talking about muscles and cells and signalling and molecules and stuff like that. And finished up the talk, and a whole lot of patients and their partners came over and said, "Yeah, Prof, that was relatively interesting. But you're not addressing the problem." I thought, like muscle mass and function and stuff like that and survival. And they said, yeah, it's not the major problem. Our two major problems which cause us the most discomfort, most worry is incontinence and our sexual health. So we were looking at the wrong things. So our team turned our attention to get a program of research. You have to respond to what the patient needs. You have to respond to answering the questions that they feel are important. And so we developed a series of projects to have a look at sexual function in particular in these men with prostate cancer. Now, the first thing that you might ask, and certainly a lot of my young students ask, is who cares? They're not that interested. Men and women, they're not interested in sex, surely. But that's not the case. I mean, there's very solid data here indicating, this is just one study from 2012, Journal of Clinical Oncology, 90% of men with prostate cancer will experience significant sexual dysfunction. So it's a problem because if you compare it to other patient populations, these are other chronic diseases here. This is prostate cancer. These are healthy men. This is, again, another study in 2013. We have a look, prostate cancer way up here. The incidence of erectile dysfunction is way higher in these men than other patient populations. It's a really big issue. And men are interested in getting this addressed. 50% report unmet sexual health care needs. And they rank sexual health as the most unmet need as a prostate cancer survivor. I'll skip quickly through this, answering the question of my young students. Again, when they ask, do old people actually have sex? Being 50, coming up on 54, I like to think so. I mean, this is just a couple of studies here. There's millions of them, but just an example here. We have Australian men, about 30%, 75 to 95 years of age, are still sexually active. I don't know about athletes, but active. I mean, they give it a shot, I suppose. But although, you know what Nike says? If you have a body, you're an athlete. 50% consider sex as important. So it is important to them. So we thought, let's look at this. And one of our first forays into this was a paper we wrote as a perspective paper that Prue Cormie led here, looking at exercise therapy for sexual dysfunction. We proposed it and say, look, exercise might address some of these issues. You go, why? How would that work? There's very good evidence, particularly in overweight and obese men, and also in men with hypertension, men with type 2 diabetes, in these other patient populations, that exercise has really improved their sexual health. Why not for prostate cancer? Let's have a look. So we actually launched on a small RCT. It was only 3 months in duration. We measured sexual activity and also libido as well. These are men all undergoing ADT. Now, as you can imagine, if you take testosterone away from a guy, not that interested in sex, libido really declines without testosterone. That, of course, creates problems, particularly with the partner. So this is the data from this particular study. We're looking at exercise here. This is at week 0, and this is at 12 weeks. We see a lovely maintenance of sexual activity. Here, usual care declined quite markedly, and a significant difference between those groups there. So the exercise maintained the sexual activity, and this was driven mainly by improvements or changes in libido. If we have a look here, this is any interest in sex, and this is the percentage of participants. In the exercise group, it actually went up, although not significantly, and the usual care went down, resulting in a significant difference between the two groups. If we look at a major interest in sex, we only got about 17% at baseline, but after 12 weeks, the usual care group is nothing. All right? No one falls into that category. So it seemed to be related to improvements in quality of life. We had the guys in the gym, they were lifting weights, they were hanging around with their mates. So when they got home and their partner tapped them on the shoulder, they were much more responsive. They felt healthier, they felt better, they felt more virile. It's a great outcome. Again, in reporting that, this is a world first done here at ECU. What we're doing now, though, is using that as a strong motivator, because we say, look, you know, you'll lose some weight, you'll feel fitter, you'll get stronger. The guy goes, I don't really care. But if you say your sex life will improve, they get all of a sudden very, very interested in lifting weights. It's a good motivator. Okay, changing tack again. This is another study which we have ongoing at the moment. If you have a look at all these other research that we've presented tonight, it's been down the track. The guys have got lots of side effects. They've been on ADT for 6 months or more. They've had radiation therapy and all these other things. They're falling into a hole, and then their oncologist or urologist says, time to dig them out, so let's get them exercising. And so again, our clinician said, this doesn't seem a very good approach. Why don't we start them off with the exercise and not let them fall in the hole in the first place. But it hadn't been done before. No one has ever done a study where we actually intervene at the time they commence treatment. We wait till they get really, really sick, and then we come up with an intervention. Not a very effective way. But on the flip side, they've just had a diagnosis of cancer. They've just started on testosterone suppression. Can their body, A, respond, and B, psychologically, are they ready to actually embark on a new lifestyle that involves exercise? Let's find out. So, this was a study. This was actually supported by AbbVie. This is a major, massive pharmaceutical company which has been quite supportive of a lot of our research. And it was a randomised control trial looking at their product, which is Lucrin. And all of these guys actually started their exercise intervention within 10 days of their first injection of ADT. And it involved moderate to high intensity aerobic and resistance training for 12 weeks. The usual care intervention, we just asked them to maintain their normal lifestyle. So, to the results, this is body composition. What we observed, this is the between group differences, so comparing the two groups over the 12 weeks. We see that whole body mass actually decreased, favouring the exercising group. Their lean mass went up markedly, and also the arms and legs here, and their fat mass went down. Not went down, but it was lower relative to the usual care group. Percent fat and also trunk fat. What does this say? If you initiate exercise at the time you start your ADT, you will not lose as much muscle, you will not gain as much fat as if you are under usual care. So the body seems to, even though you've got this suppression of testosterone, it retains the ability to actually maintain your body composition. We had some really nice improvements in quality of life. In particular, sexual function was really maintained in the group that did the exercise as well. Some nice benefits in terms of fatigue as well. So conclusion. Not the conclusion of the talk, folks. Sorry, don't get excited, John. John was about to jump up and wind me up. Conclusions from this study. Exercise diminishes the adverse side effects of ADT during the initial 3 months. Exercise medicine should be, and I would say must be, commenced at the same time that the patient initiates their ADT. It will actually stop, or at least reduce, the majority, if not all, of the side effects of testosterone suppression. Importantly, PSA and testosterone were not affected, so it did not compromise therapy intent. It wasn't so long ago, 5-10 years ago, when we go out, Daniel and I and Prue, and we go out and talk to clinicians, and they sort of be divided 50-50. 50% of them would say, if you want to exercise, that's fine. It's not going to hurt, but it's probably not going to help. And 50% would say, don't exercise. All right, you've got cancer. You're having chemotherapy. You need to rest. You need to recover. You need to get over it. Now, 10 years later, it's still 50-50. 50% of clinicians, I think, will say to their patients, look, if you want to exercise, that's fine, it doesn't hurt. There is not a single study, there is not a single clinical observation to indicate that exercise exacerbates cancer. All right, so it doesn't make your cancer worse. It doesn't break off little pieces and make it race around your body. That doesn't happen. 50% of clinicians, certainly in Perth, now say to their patients, you will exercise because this is a critical part of your care. Changing tack again, this is looking at some nice research we did around breast cancer, and in particular lymphedema. Lymphedema is the accumulation of fluid in the tissues, usually of the upper limbs in the case of breast cancer, and affects about 20 to 30% of breast cancer survivors. Now, historically, the therapist would advise the patient not to use that limb, or if they did, don't use it with any great effort. Don't lift weights, don't do anything which is of any high intensity. The problem with that is, an exercise scientist, you look at it and you go, well, the limb is only going to get weaker. Their function's only going to get worse. The vascular function in the limb is only going to decline. Their lymphedema is just going to get worse. It's not an option not to exercise the limb. So we couldn't come up with a physiological mechanism by which the exercise would make the lymphedema worse. So we thought, let's evaluate it in an RCT, randomised controlled trial. And so this is, firstly we did a acute study where we compared lifting heavy weights versus light weights, because therapists had changed a little bit and they said, well, you can exercise the limb, but don't lift anything heavy, just lift really light weights. Again, drawing on sports science research, that would only cause greater inflammation. Doing a really high volume of light weight, that's a recipe to get really sore and produce a lot of inflammation. It should make it worse, not better. Lift heavy weights, you'll have more benefit, you'll get stronger. This is pre the session and then immediately post, 24 and 72 hours post. No exacerbation of the lymphedema whatsoever, whether lifting light weights or heavy weights. If we have a look at regular exercise, this is over 3 months, no difference. In fact, no exercise, they had a slight increase, but it wasn't significant. Low patient numbers and a slight decrease for heavier weights. So even exercising, lifting weights over a 3-month period does not seem to exacerbate lymphedema. And that was the paper that we published from that. If we have a look at can they actually respond and get stronger, this is chest press. We see some nice improvements with both heavy and light weights here and also seated row. No change in the non-exercising group. So the women retained the ability to get stronger, which is really important. They're improving their function and their structure. No difference between the two groups, whether you lifted heavy or light weights. But likely, if you would push it out past 3 months, you would see that the heavier resistance training would be more effective. That's what we see in other studies there. And that was the paper that we published there in Journal of Cancer Survivorship. Once again, this is a world first for ECU, the first group to actually do this type of intervention with women. Very common problem in breast cancer. Okay, a lot of people say, well, that's really interesting, guys, but how do you actually do it in the real world? How do you actually translate it? So we've been working very hard, because this is a key question. How do you actually implement this? I'll never forget Terry Slevin, who's head of research for Cancer Council WA, and back in the day we were talking about implementing these exercise interventions. He said, oh, geez, Rob, man, how many people could you put through your programs? And oh, Terry, it'd be hundreds, easily. And he said, Rob, we have, at the time, 6,000 new cancer diagnoses each year. It's now over 12,000. You're a little behind the pace. You need to work out how we're going to do this and translate it out into the broader cancer community. So this is one of the initiatives that we've been working with the Cancer Council here. It's called Life Now. This is an exercise program which is available to any person within 2 years of a cancer diagnosis. It's a 3-month community-based exercise program which is led by exercise physiologists. We now have, we all know the exact numbers, but it's I think it's well over 600 now that have been through the program. I get confused. We've done evaluation on this, looking at them pre and post. We see very high compliance here, around 73% attending the program, which is great, so they will actually come and do it. Another common criticism of exercise medicine is, oh, my patient won't do it. And I have to remind the physician that the patient doesn't take the tablets either. Very strong study looking at statins. Statins are used to reduce cholesterol. Very strong study published in the New England Journal Medicine showed that at 12 months, 50% of patients do not renew their statin prescription. Okay? Most studies indicate that with exercise at 6 months, you're looking around an 80% compliance. Depending on the study and the level of interaction and support, you're looking around 60 to 75% compliance. So actually, the truth is compliance to a quality exercise program is actually higher than drug compliance. These are some of the improvements here. We're showing great improvement in blood pressure, waist circumference and function, quality of life, reduction in fatigue from this study, and we've just building up this database at the moment to prepare our paper for publication. Another translational aspect to our work is our partnership with Genesis Cancer Care, and you'll find a brochure on your table there. Genesis is a medical provider. They've built a beautiful facility over in Shenton Road over in Joondalup there, and we've got a really close partnership. And this was brought about because when they were building their facility, they're putting in chemotherapy suite and radiation bunkers, etc. And our clinician colleagues said, you have to have an exercise clinic. And I think the general manager said, what's an exercise clinic? But Nigel Spry and Andrew Dean, I think, explained it to him. And what they did was they had 3 bunkers over there. They have to have these special bunkers to put the radiation units in. And they only commissioned 2 of them. And what they said is you can put your ECU, can put your exercise clinic in the 3rd bunker, which is what we did. It's nice big room. We kitted it all out. We've got a great facility. Why would you do that? Because it's where the therapy's happening. It's very important that we actually have an exercise facility right where the patient is being treated to make it as easy as possible for the patient to engage in a quality exercise program. which is delivered by our accredited exercise physiologists. They're all trained in exercise oncology. We're rolling the latest research. As it comes out of our labs, out of our trials, we're rolling it straight into these programs. I think what's exciting about this is I don't know of any other facility in the world whereby the patients are receiving their exercise medicine at the same place that they get their chemo and radiation therapy. It's always 2 blocks down the road or 5 k's down the road. All creates problems. You just had chemo, last thing you feel like doing is driving a couple of kilometres to go find a park and then go to the gym. It's just, it's not going to happen. But either immediately before their session or immediately after, they can do their session while they're in the same building, has huge advantages. So we're running a pilot trial to evaluate effectiveness. We've done 176 consultations to date, 74 commencing the exercise program. We're seeing some really nice improvements in balance, chest press, leg press, seated row, so they're getting stronger, they're getting aerobically fitter. They're losing lean mass, and a slight loss in fat mass here. But remember, these patients are receiving chemo radiation therapy at the same time. So normally, if they weren't exercising, we would see massive declines in all of these parameters. So we're actually preventing that decline or actually lifting it a bit. So I want to finish off just talking about exercise as a medicine. We think of exercise as nice to do, and how much does it actually change our internal workings? But the fact of the matter is that when you go out and exercise, every single system, even your skin, changes markedly, both acutely and then it adapts, and you get longer-term chronic adaptations that occur. And it's highly specific to the mode of exercise that you do, the dosage that you are prescribed. There's a complex interaction with other therapies like chemo and radiation therapy. Also, your nutritional intake and your psychological state all interact with this. So we're pursuing our exercise medicine research. The opportunities that we're looking at very closely is how we can enhance treatment effects. Can we make chemo and radiation therapy more effective? In fact, we're working with Genesis now to have an actual cycle ergometer so the patients can cycle while they're actually receiving chemotherapy, because there's good pharmacokinetic reasons as to why they'll get a better effect from that. Ameliorate the treatment side effects. Inform new therapeutic targets. I'll come back to this one. Increase survival, of course, and then move towards personalised exercise medicine rather than these physical activity guidelines. Hey, we'd be happy if the cancer survivors just adhere to the guidelines. That's going to be a huge step forward. But we need to move towards more specific exercise prescription. Because we've got our illustrious leader, who's a chemist, I just want to talk a little bit about some of the mechanisms here, just briefly. This is a very interesting study, and there's more of this research coming out. This is an actual animal study. It's not an animal study. It's a human study. They had 10 male individuals who spent 60 minutes of cycling. They drew blood and took serum, pre and post the exercise. They have what are called cancer cell lines. Okay, they're actual human prostate cancer cells, which they've isolated and grown. And what they found is that they poured the blood, or the serum I should say, over these cancer cell lines. They poured the pre-exercise blood and the post-exercise blood. 9 out of 10 individuals, they observed growth inhibition, so the tumour cells did not proliferate. When they put all the exercise serum together, they found a 31% inhibition. This is just some of the data here. This is the actual cell lines here at 96 hours. And here we have just a control condition. This is at rest, so this is the blood prior to the exercise, and this is after the exercise. So a 33% reduction in the actual growth of the prostate cancer cell lines. So when we exercise, there are chemicals being produced. We got a new paper today from our colleagues over at the University of Queensland showing some interesting data there. There are chemicals being released into our blood, some of which we don't even know what they are yet, which seem to have a very strong suppressive effect on tumour development. There's several other mechanisms at play here. I'll go quickly through those. The endocrine system, of course, is very impactful, particularly on hormone-responsive cancers, such as ovarian, breast and prostate cancer. Immune system function changes. When we exercise, our immune system gets hyped up. It becomes a bit like Wolverine. when we exercise. It is much better at seeking out prostate cancer cells. It can recognise, cancer cells. It can recognise them more effectively, it can hone in on them, and it's much more savage on them. Inflammation, exercise reduces systemic inflammation. Epigenetic changes that occur. Some very interesting work done by Elizabeth Blackburn. She's an Australian who was a Nobel Prize winner for medicine, actually. And she did all the work on telomere research. And what they found is in a lifestyle intervention in men with prostate cancer, the telomere length was actually improved in these patients. So that could be a very important mechanism. Blood perfusion hypoxia, a paper came out a couple of weeks ago showing that when we exercise, of course, our circulation goes up. Tumours have very dysregulated and dysformed circulation, and they thrive in a hypoxic or low oxygen environment. When you exercise, circulation goes up, oxygenation goes up, and that is a bad environment for tumour cells. So it could be another mechanism that's been looked at. Insulin, glucose and IGF, these are critical hormones, particularly in the involvement in a range of cancers, particular prostate cancer. And of course, exercise produces dramatic changes in the insulin IGF axis. Oxidative stress, adipokines and myokines, these are cytokines released by muscle and fat tissue. Platelet cloaking is a really interesting one. This is being pursued by our colleagues at University College Dublin. And in people who are sedentary, and particularly people who are overweight, their platelets are sticky. These are elements in the blood, and that's one of the main causes of cardiovascular disease, because the platelets tend to adhere to the vessels and to the other cells, and that's what causes a lot of the cardiovascular disease. But they also adhere to circulating tumour cells. Now, when they adhere, the body's innate immune system can't recognise those cells and destroy them. Even a modest amount of exercise reduces platelet stickiness and adhesion, and actually is probably a mechanism by which the body's better able to fight circulating tumour cells. So I just want to finish off, reiterate a couple of points. Exercise is not a single medicine. We're starting to learn this. We're starting to learn the complexities of it. The muscle system is highly important in this whole process. We now know that the muscle system is the largest endocrine system in the body. It's just a huge organ which is pumping out hormones and chemical messengers, molecules continuously, impacting all the other tissues in the body, including tumour cells, and has strong suppressive effects if we manage it properly. We have to maintain the size of that pharmacy within our body, in other words, maintain our muscle mass, and we have to activate it regularly so that it's dispensing medicine out to fight cancer and other diseases. The problem we have is, and this is a quote directly from Professor Nigel Spry, are we prescribing antibiotics for contraception? In other words, are we giving the correct exercise medicine to treat the issue that we're targeting? So this is something we're in early stages here. It's like the early days of chemotherapy when doing research in that area. We didn't know a lot of the specifics. Just want to finish off. This is a very exciting trial which has just been announced last week. But Movember is contributing $9 million for a global trial of of exercise in men with advanced prostate cancer. 900 men internationally. The outcome is survival. This will be the first prospective study looking at exercise as medicine to actually shift survival. There'll also be extensive intervention of mechanisms possibly influencing tumour biology. ECU is the lead site for this study internationally. Oh, no, that's the wrong slide. Oh. Okay, so I think it's time for me to wind up, and I'll finish my presentation on this side. I just want to acknowledge, of course, I'm just the person who stands out the front and gets to present the data. We have obviously a very enthusiastic and extremely talented team. I presented recently at the entrepreneurship, and my number one rule, Professor Jones, you would remember, is always hire people that are smarter than you. When you're me, that's easy, okay? But other people, that's probably a little bit harder. But our team, of course, which is very extensive, our research team here and our collaborators, in particular our clinical collaborators, we wouldn't have a research program. We would have none of those studies if we didn't have clinicians who actually were referring patients and supporting us in our work. And in the main, coming up with the questions. They're the ones that come to us and say, this isn't working, can you have a look at it? So they're extremely important. Of course, our research participants that give up their time and actually come and be guinea pigs in our study, as well, our support team, our administrative staff, technical staff, our research students, all of our funders as well. You can't do research without money, guys. It takes a lot to keep the lights on, do the work, pay the postdocs. They've got to be fed. So we're very indebted to all of these groups for all the support that they give us. And now we get the thank you slide. Thank you very much, everyone.